My name is Hüseyin. I'm working in Bakırköy. I will be talking about RDoC, Research Domain Criteria. Professor Dost will be talking about that in a detailed format, so you can ask him the questions as well. RDoC is an alternative and it's a new method. It's not a complete definition system. Let's have a look at that. Then I will tell you how it works. And then I will give you an example which can be used in the clinic. RDoC is an alternative to DSM. Biological, behavioral, or the cognitive scientific approach might be uttered by the next speakers, but this is all about the nerve science. Ahmet already uttered what the criticisms are about DSM and ICD. Both DSM and ICD statistically are based on the clustering of the symptoms, coexisting symptoms, and they're clustered, coincidentally and statistically, they coexist. But ICD is not related to the biological roots of that. There might be some results about the biological elements, for example, schizophrenia, biological reasons might be found along with neuroscience, but these are all coincidences. The descriptive diagnosis systems are not precursor of the diagnostic systems. Of course, there are many problems in that regard. Early diagnosis is not a problem because early diagnosis means that you diagnose the patient without the symptoms appear, but DSM or ICD, they don't provide us with such a method. And in terms of follow-up to treatment, this is not enough. For schizophrenia, before the symptoms appear, years ago, biomarkers or the biological changes or brain changes or molecular or brain anatomical changes happen long before the symptoms appear. Therefore, the subtypes can be defined and the treatment can be followed in a better fashion. ICD and DSM seem like a shadow game. You can see here, we do see the shadows. Something is happening within the body, human body, and something is happening on the brain, and they come as symptoms, and we name those symptoms and we group them. If there are two open hands, we call them bird. One is open, one is closed, then it's a dog, you can see on the shadows. But behind all of them, there are two hands. How these hands stand and how these two hands are related to each other better. And how can we answer this question from a biological point of view? NIMH, USA National Mental Health Institute started the RDoC project. These matters have been discussed for so many years, but NIMH took such a decision, and the studies in the framework of RDoC are supported more. RDoC is not a definition system. and this is for the follow-up of the clinical cases, and it can develop a new method, or it can set a base for a new method development. Again, the new treatment method development, we can use it as a framework. We call it as framework in English. The basic presumptions of RDoC: mental disorders, psychological disorders, or emotional swings. We define them differently, and RDoC calls them all mental diseases, because the main allegation is that all of these diseases happen because of the changes in the brains, or the disorders in the functions of the brain. Differently from the neurological diseases, there is a lesion. But in the psychiatric problems, according to this assumption, is about the relations of these issues. Therefore, the circuit definition is being used. This circuit is not something tangible, physical. I noticed this logo. It's something like this logo. This is our brain. There are three components, and I will be telling you in a minute. And they are all interrelated, and there's a function out of that relation. And this function makes us to have our daily life, and this can result in some pathological situations. And this is away from the mechanical approach. Pathological and non-pathologic, they're not differentiated. The functions, how do they show the functions, the relations function, are needed to be seen. Genetics and neuroscience data are being gathered together within this framework, and then these collected data are progressed and new data are being processed from them. And the purpose is to develop new diagnosis, new diagnostic methods, early diagnosis, and new treatment methods. And as these methods reach maturity, the clinicians can use them. The data under the roof of RDoC is not appropriate for using in the clinics.
In the last 5 decades, in medicine, the pathologies that have been detected, they make the early diagnosis possible, and they bring about the effective treatments, the effective treatment with the mild effects, adverse effects. For example, in infectious diseases, if we can find the agent, we can administer this specific antiviral or antibiotics. In diabetes, for example, if we can see the degenerations in the cells, they deteriorate the insulin cells and we replace it, or cancer, if we administer certain agents, we can get good treatments. In the last 5 decades, especially for the diseases with high mortality, in heart diseases with the high comorbidities, in anomaly neoplasma, there have been advancements. We need to find this method, and why cannot we have the same progress in psychiatry? Because we know in psychiatry that psychiatric disorders, especially chronic psychiatric disorders, cause disabilities, and it also brings about the social and economic burdens. So the neuroscience, the examination of brain and behavior relation with the genetic developments and neuroscience. We see the symptoms, but beyond them there are emotions, and there could be cognitions and emotions. And as I have pointed out, RDoC, under the data under the RDoC, the data are collected under RDoC are not appropriate for the use of clinicians, but they're promising, if I might say so. And RDoC focuses on neural circuits, and there is an uplink of the circuit function. This is about related to the function. It's the determination of the circuit, and the downlink is determining the genetic or molecular factors. And the potential effect on the clinic is that, as NIMH promises, if it is appropriate and if it brings about good results, the hypotheses are proven and developed, the results will be possible. It's a newly tried system. How will RDoC function? There is RDoC framework. It is a simple list. There are lines and there are columns, and we write certain things through these columns and lines. Yep. In order to evaluate this table, neuroscience, genetics, pathology, physiology. Regarding the neurosciences, all RDoC framework plans to collect all the related data, and there are certain systems defined. There are 5 systems, and the number of systems can be increased. If we take a look at this, there is a negative value system, positive value system, cognitive systems, social systems, and stimuli and regulating systems. The stimuli and also regulating systems are like sleeping, which regulates the body, and the others are the systems which affect the behaviors, visible behaviors. Of course, if we take them as a circuit, there is a behavior, and there are many factors affecting this behavior. I will use this logo here. As you see, we see the behavior. The brain realizes a function. The systems are affected among each other, and there are subsystems. And the subsystems are affected through and among each other, and it causes a symptom, or it causes a lesion as something visible to us, I mean. There are a lot of things, maybe thousands of things published in NIMH, genes, molecules, physiological parameters. We write these systems to the lines, and the genes, molecules, cells, circuits, physiology, behavior, self-report, and the paradigms. They are written onto the columns. These are fixed. These are fixed. I will show you in the table. You can see the negative valuing system. This is not related to pathology. This is, as we know, basically it is the fear, anxiety, and grief. It is responsible for the responses. Negative balance system is actually composed of 5-6 systems. We have the fear, frustration, the loss. When we say first, this is a frustration, and there's also positive balance system. This is a simple table, but there are thousands of things that can be written on these columns, and it is self-updating. We can write new things, some things that we already very well know, and some things we are not very familiar with, but these we don't use in clinics or in these are the things that are not asked to be written by DCM ICD. And the negative balance system is is the circuit which causes the fear behaviors, and there is a normal fear which includes the adaptive responses to the system. This is from an MH system. I took out this table from what I know, but it's just 1/5 of it. You know, in many of this, I didn't include all because it is not readable. But I've written down here. There is acute fear and threat. This is something we define in clinic. It is one of the important components of anxiety disorders, but in non-clinical settings, in psychotic disorders and stimuli control disorders, there is the system functioning. Of course, this is about collecting the data. When we consider this table, what does RDoC promise us? It's about establishing relations among them, working on them, studying them, and it says I'm going to support you. For example, the data conductivity and endocannabinoid relationship related to an anxiety or acute fear. And here they are not double, so there are complex relations. All of the things I have not written and we don't know, they should be studied together at the same time, and they cause a certain result, and this result is the response of fear. And they are also working with other subsystems, and there is a relationship between the subsystems. For example, serotonin receptors. Can I get the presentation back, please? If there is anxiety or mixed anxiety, if when we see an anxiety, for example, in BDNF polymorphism, this can determine the response of anxiety to behavioral therapies. If we can prove this, maybe regarding without exposure about anxiety, we can check the polymorphism of BDNF genes, and if there is a clinically responding polymorphism, we will give the therapy, or for anxiety we administer SSRI, and for serotonin receptors maybe a change in the serotonin receptors or glutamate system, a change in the glutamate system. If the response changes to the SSRIs, this could be more effective or less effective. The acute threat and fear, if there's a pathology, we determine a sub classification. We say BDNF A or BDNF polymorphism B For example, for A therapy, for B the SSRIs, and regarding this pathology, we will have a marker, and this marker will be determined through screening tests, and before we can determine them before the pathologies occur, or we will recommend the changes in lifestyle. We will have the early intervention chances, and this will bring about better results and better therapies, and it will decrease the economic and social loss, and also decrease the disability. Actually, this is not something brand new. It is about getting data available. RDoC might be promising, but there might be some points to make criticisms. This is about the behavioral parameters or psychological parameters. They're not on the upfront. The other outside factors, environmental factors, for example, trauma. Trauma is not listed in this list. For trauma, it says trauma decreases oxytocin levels, or that could, this RDoC framework can be developed in this way. However, this is a biological working system, especially for genetics and for neuroscience. And there are the new imaging systems, and we know that these new imaging systems will contribute to this, especially the circuits, to be evaluated with the functional factors. Physiology we evaluate that. However, in clinic we never use it almost, and we know they are used in the studies. In a nutshell, that is my presentation. I know it's been kind of messy, but thank you very much for your attention.